The committee will come to order. A quorum is present. Without objection, the chair is authorized to declare a recess at any time. Since we are working in a virtual format today, I'd like to go over a few housekeeping items before we proceed. First, if you're experiencing connectivity issues, please make sure you or your staff contact our designated technical support so it can be resolved immediately. Members participating remotely, which everyone is today, must continue to use the video function for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render the member unable to fully participate on camera. It is committee policy that members will remain muted when not recognized, just like turning your microphone on or off during a hearing in person. This is out of courtesy to all members on the committee, and so that background noise does not interfere with another member who is recognized to speak. When you are recognized, you will need to unmute your microphone and pause for a couple of seconds before speaking so that we will be able to hear anything you say. If you wish to be recognized, please raise your hand using the Zoom raise hand function, unmute your microphone, and ask to be recognized. In order to ensure everything members say is captured on the live stream of this hearing, I ask that members pause for 2 to 3 seconds before beginning to speak. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteranaffairs.hearings@mail.gov. It will be uploaded to the committee document repository. Please keep in mind that you will need to refresh the repository page as it does not automatically update. Without objection, members will be recognized in order of seniority for questioning witnesses. This makes it easier for me to make sure all members participating have an opportunity to be recognized. Does any member have a question about the conduct of this hearing with members participating remotely? Seeing none, I will now recognize myself for an opening statement. While America's healthcare systems recover from the pandemic, they are also contending with the enormous challenge of one of the largest generations in history, the baby boomers, entering their later years in need of care. These seniors will live longer than any generation before them, but with more complicated health needs than any health system has ever had to contend with. For VA, the preparation for this silver tsunami is crucial since it will ultimately make up nearly half of its patient population. Over the next 17 years, VA will have doubled its spending on long-term care services, nearing $15 billion to meet these needs if the trajectory of care does not change. There are not enough beds or staff in institutional settings in the country to meet the projected need. And it is not what veterans want. 90% of Americans wish to age in place. They want to stay in their home and have the care they need. One of VA's best kept secrets is their home and community-based services. VA funds or administers over a dozen beloved programs, from veteran-directed care to home respite care to adult daycare, but they are not uniformly available at all facilities or regions, meaning thousands of veterans go without these services altogether or endure months or years on wait lists. Early in the Obama administration, there was an effort to rebalance long-term care spending at VA from the institutional side of the ledger to the non-institutional side. This went on steadily until peaking in 2017, when non-institutional care spending accounted for 36% of the total long-term care budget of the VA. But in recent years, non-institutional care spending has slipped, decreasing to 30% of the budget in fiscal year 2020. Expansion of home and community-based programs has also stalled. At his 2017 confirmation hearing, Secretary nominee Shulkin committed to expanding the extremely successful veteran-directed care program to every VA medical center within the next 3 years. This program allows veterans to hire family members or friends to provide personal care services in the home and purchase goods and services that will allow them to remain in their home. The Veteran-Directed Care Program can serve 3 veterans for every 1 residing in a community nursing home at VA's expense unnecessarily. Yet VA has made little progress in the last 5 years to serve our veterans in their home while saving precious healthcare resources that can be reinvested into better care. The subcommittee hopes to hear from VA why so many facilities are without critical supports like the Veteran-Directed Care Program, what needs to happen to expand these programs, and how Congress can assist in addressing these critical goals. We will also discuss the possible expansion of VA's interagency work with the Administration of Community Living within the Department of Health and Human Services. I have to note that ACL was invited to participate in today's event, but declined. Lastly, we will hear from 2 VSOs who work almost exclusively on behalf of veterans whose very well-being is derived from these programs. In the last 10 years, Congress, VA, and stakeholders have largely focused efforts on expanding the Comprehensive Caregiver Program, a landmark resource for those disabled by their service. While it is an essential program to get right, VA has dozens more programs that are just as important to get right. The scale of the silver tsunami is something VA cannot afford to get wrong. Millions of veterans and their families are relying on us to ensure their later years are as safe and dignified as possible. With that, I'd like to recognize Ranking Member Radewagen for 5 minutes for any opening remarks she may wish to make. Ranking Member Radewagen, you are.
Yes, thank you, Chairwoman Brownlee. Thank you. Talofa lava. It's my pleasure to sit in for General Bergman today as the acting ranking member of the Subcommittee on Health. We are here this morning to discuss how well VA is prepared to meet the long-term care needs of our nation's veterans, including the growing number who prefer to stay at home as they age. On March 3rd, 2020, just days before COVID-19 turned the whole world upside down, the subcommittee held a hearing very similar to this one. A lot has changed since then, but what has not changed is the fact that veterans need long-term care in greater and greater numbers, and that more and more of them are choosing home and community-based programs that allow them to age in place and postpone or prevent nursing home care. These dynamics are placing demands on VA's long-term care programs and requiring VA to get creative with respect to providing care and support in a veteran's own home. One of VA's newest and most creative long-term care programs is the Veteran-Directed Care Program. The Veteran-Directed Care Program allocates a particular budget to a veteran and lets the veteran use that budget as they choose to get the help they need. This puts veterans in the driver's seat, empowering them with the freedom and flexibility to personalize their care to meet their unique individual needs. The Republican witness for this hearing is Rashi Romanoff from the Elizabeth Dole Foundation. Her testimony calls the Veteran-Directed Care Program the model for what the future of aging in place looks like, and I fully agree with her. I look forward today to learning how this committee can support veteran-directed care and also to exploring how the veteran-directed care model of personalized care and personal choice might benefit veterans in other areas. I'm also interested in learning what additional challenges the pandemic has caused for VA's long-term care programs and what progress VA has made to respond to the failures found by the Government Accountability Office in a February 2020 report on VA long-term care. That report found persistent problems with respect to workforce shortages, geographic misalignment, and specialty care, and made 3 recommendations for improvement. VA concurred with those recommendations, but I do not believe they've been addressed in the 1.5 years since they were made. I hope they will be very soon. Finally, I'm also eager to learn how VA and Congress can better support the caregivers of aging veterans. Veterans who wish to stay at home as they age can often only do so because they have support from a family member, friend, or paid caregiver. We must pay attention to the needs of caregivers and help connect veterans, particularly those with limited family support, with caregivers or medical foster homes, so that they are not unfairly pushed into institutional care. And while we're on the topic of caregivers, I have one final note before I close. I mentioned a moment ago that the minority witness for this hearing is from the Elizabeth Dole Foundation. The foundation does life-saving work for military and veteran caregivers and is, of course, named after Senator Elizabeth Dole, who was inspired by the needs of her husband, Senator Bob Dole. Senator Bob Dole celebrated, I believe, his 97th birthday last Thursday. Senator Dole will celebrate her birthday this Thursday. I wish them both many happy returns and thank them for their continued service to veterans, caregivers, and to our great country. With that, Madam Chairwoman, I yield back.
Thank you, Ms. Radewagen, and we are very happy to have our ranking member of the full committee joining us today, and I'd like to give the ranking member Bose, the opportunity to make some opening remarks.
Hey, thank you, Chairman Brownlee. It's my pleasure to be here today, virtually today, to discuss long-term care. The veterans population is getting older. As they age, veterans are increasingly choosing to stay in their own homes rather than seek care in the nursing homes. Veterans earn their VA healthcare benefits. I support giving veterans a choice of how, where, and when to use those benefits. That includes using them to age in place at home for as long as they can. I look forward to learning this morning about how well the VA is prepared to offer veterans the support they need to avoid nursing home care. And it is what veterans want. Home and community-based care is a model of care that for more and more veterans are choosing for themselves. Home and community-based care is also less expensive than institutional care. Given that, I look forward to hearing how the VA intends to right-size its long-term care workforce infrastructure budget to reflect growing demands for home care-based care. I thank all of the witnesses today for being here. And with that, Madam Chair, I yield back.
Thank you very much, Mr. Bost. And with that, I'd now like to introduce our first panel from the Department of Veteran Affairs. Testifying before us this morning is Dr. Scott Hartrough, Executive Director of Geriatrics and Extended Care within the Veterans Health Administration. Welcome back to the subcommittee. He is accompanied today by Dr. Catherine Kelso, also of the Office of Geriatrics and Extended Care. I will remind our witnesses once again to please just pause for 2 or 3 seconds before speaking so that the recording will capture all of your words, and please remember to do so again when answering member questions. Your written statement will be included in full in the hearing record without objection. Dr. Hartrough, I now recognize you for 5 minutes.
Thank you. Good morning, Chairwoman Brownlee, Ranking Member Bergman, and other distinguished members of the subcommittee. I appreciate the opportunity to discuss the multiple VHA programs available to veterans who choose to age at home. I'm accompanied today by Dr. Catherine Kelso, the Deputy Director of the Office of Geriatrics and Extended Care. For the first time in U.S. history, adults over the age of 65 are on pace to outnumber children under the age of 18 by the year 2034. As veterans age, approximately 80% will develop the need for long-term services and supports. Many of the VA's top efforts focus on helping veterans as they age at home, and the VA operates a spectrum of home and community-based services. As mentioned before, 90% of Americans wish to age in place in their homes. VA provides and purchases an array of home and community-based services to support veterans in aging comfortably and safely and providing institutional care only when necessary. Examples of VHA provided home and community-based programs include Adult Day Healthcare, which is a program where veterans can go during the day for social activities, peer support, companionship, and recreation. Home-based primary care program, where the primary care is actually provided to the veterans in their homes. Homemaker Home Health Aide, which provides a trained individual to help the veteran take care of him or herself. Medical foster home care is an alternative to long-term care for veterans that elect to receive their nursing home level care while living in a private home setting. The palliative and hospice care program seeks to optimize quality of life and symptom relief for veterans with serious illness. The Respite Care program pays for a person to come to a veteran's home or for a veteran to go to a program to relieve the caregiver for a period of time. Skilled home health care services are short-term help provided to veterans if they're homebound or live far away from a VA medical center. And finally, the Veteran-Directed Care program gives veterans of all ages the opportunity to receive home and community-based services they need in a consumer-directed way. Evidence is demonstrating that appropriate targeting and use of programs and services available through home and community-based services can reduce the risk of preventable hospitalizations and delay or prevent nursing home admissions and their associated increased costs. While VA has increased access to home and community-based services over the last decade, we recognize the need to accelerate the availability of these services. VA will focus on immediate actions to expand VA provided and community purchased home and community-based services, modernize systems for healthy aging, modernize and improve facility-based care, improve access with technology, geriatric expertise, and develop data definitions and processes. There's a veteran experience story that I would like to share regarding veteran-directed care. A veteran has Parkinson's disease and a stroke, which left him wheelchair-bound. His wife had to keep working full-time and would come home to her husband on the floor sometimes with no one to help him back up. The VHA offered veteran-directed care and gave their family hope again. And their veteran and wife were quoted saying the following: "We were offered veteran-directed care, and it was like someone switching a switch. We went from just surviving. We were on fumes. I mean, burning the candle at both ends for so many years, trying to stay together. And when we got in the program and they made it so easy for us, he is able to have his wife back, and I'm able to have my husband back. We are able to dream again, and we have plans. We thought that that part of our life was over, and it was going to be just a trip to the end. It's like there was a ship that sunk, and we were thrown a lifesaver, and we would like other veterans to be able to get their lifesavers too." In conclusion, the VA's various long-term care programs provide a continuum of services for older veterans designed to meet their needs as they change over time. Together, they have significantly improved the care and well-being of our veterans, even during times of crisis such as COVID. These gains would not have been possible without the consistent congressional commitment in both the form of attention and financial resources. It is critical that we continue to move forward with the current momentum and preserve the gains made thus far. Your continued support is essential to providing high-quality care for our veterans and their families. Chairwoman Brownlee, this concludes my testimony. My colleagues and I are prepared to answer any questions.
Thank you, Mr. Hartrough. I will now recognize myself for 5 minutes of questions. So I have a lot of questions, so I'm going to try to get as many as I can in. So first, the Veteran-Directed Care Program. We heard everybody in their opening remarks talk about this program. I'm surprised the VA doesn't brag about it more. It seems to be an extraordinarily successful program. And so, in your statement, you're talking about, a plan to move towards non-institutional care from institutional care. So I guess, I feel like it's taken a long time, to kind of get to this point. We've been hearing from the VA for, since 2017 or so, that this is the goal, is to expand, but yet, the numbers show that it's not really happening. So, and particularly with the Veteran-Directed Care Program, this is a pretty simple program. Like, all of the various obstacles that may stand in the way to stand up a new program in the VA, this doesn't really require that from my vantage point. I might be oversimplifying it to some degree, but it is a program that says, here's some money, You go and find, the best services to meet your needs. And to meet your satisfaction. So it seems like an easy program to just, expand, increase. And we also know that it will save the VA money because caring for a veteran in home is less expensive than it is in an institutional setting. So I guess my question is, how can we speed this process up so that more veterans are able to take advantage of programs that they want and seek from the VA?
Yes, ma'am. First of all, most of the other non-institutional care programs are available at all VAs, with the exception of the relatively newer programs, which are the vet-directed care and the medical foster home. Those are two of the relatively newer programs. We recognize that they are very good programs. They do have a little bit differences in how they are set up, but in the last couple of years, we are trying to increase the adoption. We're currently at 68 sites for veteran-directed care. We had 7 new programs in 2019 and 6 programs so far in 2020. And then we're looking at additional spread in 2021. So yes, we're really trying to increase the at which we spread both medical foster home and vet-directed care. The medical foster home is another program in which we've added programs each year, and then also with HVPC. So yes, ma'am, we are recognizing that we need to speed that up.
Yeah. Okay, doctor. So we're gonna be watching. So the other point that I wanted to really raise is, I think through all of the written testimony, and we actually received quite a bit of written testimony for the record here today. Those witnesses aren't with us today, but I think it just demonstrates the interest from VSOs across the spectrum of making this transition and to do the rebalancing. One of the consistent barriers that people raised was just simple access to the program and knowledge about the program. I will tell you that I won't mention a name, but we have a staff member who actually works on the committee who has a grandfather who has been seeking the homemaker home health aid access. She's a staff member on the VA committee. And has been trying to help her grandfather. And it's been months and months, and she still has not been able to get the information she needs to enroll her grandfather. So that's not a good story to tell. And I think, access and information to these programs it seems to be a problem. So is that an area that you will be looking at?
Yes, ma'am. It's another topic that you can't ever over communicate access and awareness of these programs. We have expanded our veteran community partnership programs, which work with the local communities to help veterans find services, working with the veteran service organizations and others. But yes, I don't think we could ever over communicate the availability and how to get those programs.
Well, thank you very much. My time has come to a close, and so I will now yield to the acting ranking member, Ms. Radewagen, for 5 minutes of questions.
Thank you. Mr. Hartrough, what is the current vaccination rate for VA employees who work directly with elderly or high-risk veterans, namely in the CLCs and in adult daycare settings? Do you have any vaccination data on home health care workers that VA employs or contracts with?
I don't have that exact number with me, but I can take it for the record and bring it forward.
Okay. And Mr. Hartrough, one thing that sets the veteran-directed care program apart and makes it successful is the freedom it gives a veteran to choose the services and supports that best meet their individual needs. Do you think it would be worth considering how other VA programs could be adapted to take a similar approach? And how does the budget provided to veterans in the Veteran Day Directed Care Program differ from the compensation benefits administered by the Veterans Benefit Administration?
Well, first of all, with the veteran-directed care, instead of from their VBA, they work in partnership with the the Administration for Community Living, and also the area-wide agencies on aging and others. And the disability and aging networks actually have a counselor that helps them set up a budget, that helps them actually identify and interview potential caregivers. So it really does kind of help with that kind of, if you've ever tried to hire a lot of people for taking care of your own family members, such as myself, trying to make sure you've covered all the state laws and others when it comes to provide, hiring someone essentially. So it really does give them a lot of benefits with having someone to help them through the processes, so they don't run afoul of any of the state rules or regulations when it comes to hiring an individual to essentially be an employee. And then, yes, and I agree with the veteran-directed care program is very important and successful, as well as our other programs. And I'm trying to remember the first part of your question. So please, if I didn't answer yours fully, please let me know, ma'am.
Well, let's see. One thing that sets the veteran-directed care program apart and makes it successful is the freedom it gives a veteran to choose services and support that best meet their individual needs. And do you think it would be worth considering how other VA programs could be adapted to take a similar approach?
Yes, ma'am. We're currently looking at how we can pilot with even states. And so we're currently have multiple pilots where we're looking at different ways we can partner with states and dual beneficiaries to include like managed care programs. We're looking at how we can make things more veteran directed in nature with the program. So yes, ma'am, we're really wanting to start looking at outside of the traditional box that we've been in, and really look at how we can work and learn also from what CMS has learned with their multiple state pilots.
So, Mr. Hartrough, time is getting shorter, and let me insert one quick question here. Long-term care was trending toward home-based care and away from institutional care before the pandemic. Did the pandemic, particularly the outbreaks in nursing homes and state veteran homes, exacerbate that trend? Why or why not?
Well, it was kind of amazing in that during the worst part of COVID, we noticed that we were really reaching out, doing a lot of telehealth. We were doing a lot of replacement care with telehealth, but at the same time, as you said, some of our intake into long-term care decreased. But during really the deepest part of the COVID, we actually had some decrease on home care because veterans were concerned about letting anybody in their home. And unless they were like when they were hired or purchased, from agency care. So I think we've really started to see an uptick in our care that we're providing post-COVID. But yeah, I think we've learned a lot of lessons with COVID as to what we can do different when it comes to providing care in the home, either remotely, telehealth, or more with care.
Thank you, Chairwoman Brownlee. I yield back.
Thank you, and I will now call on Congressman Lamb for 5 minutes of questions.
Thank you, Madam Chairwoman. Sir, I read that there was a GAO report last year saying that there were vacancies for home health aides and nursing assistants at about 80% of the CLCs across the VA. Is that number consistent with what you know right now? Are we still facing that level of vacancy for those key positions?
At this point, I don't have the latest statistics on that, but I can get that back to you as for the record. Okay.
But if it was at 80% last year, would you agree that it's probably similar right now? I mean, have you guys gone on a hiring spree of home health aides that we didn't know about?
No, I believe it would be safe to say with some certainty that it's definitely still an issue.
Okay. And for the vacancies that exist, what is the wage or the salary, whichever the case may be, of the jobs that you're trying to fill, specifically for home and nurses?
Yeah, for our VA provided care, especially in the home-based primary care, they're primarily RNs at that level. Most of the aides works, especially homemaker, home health aide is more of a purchase program. And so the RNs, of course, are anywhere from a nurse strategy of nurse 1 through nurse 2. But when it comes to actually like the CNAs that work in our community living centers, they're anywhere from most likely a GS4 to a GS6 range. So that it's definitely one of the, as in the private sector, it's one of the lower ladder type positions with pay.
Do you feel that you're offering more than your sector competitors, or would you?
Well, I think to really speak on behalf of how much the nursing office has been really working on this, they've been really looking at how they can really offer nurses, nurse practitioners, and LPNs and others the opportunity to help with anything from educational debt reduction to potentially a step increases to other incentives. So both our human capital management, the Office of Nursing, and others are really looking at how they can improve the staffing and really looking outside of the box as to what we can do. And many times we're not the leading payer by any means in our own community. And such as that, there's like a pay cap that we have for current RNs makes us at a disadvantage many times for communities, especially in high cost of living areas, such as in California and Los Angeles, for example. Some of your more metro areas, it is really difficult to match some of the cost of living for.
Well, thank you. Problem we should try to fix. I mean, I can't speak for everybody, but I think you'd have a fair amount of support on this committee for the idea that the most crucial component of providing care to these people is the quality of workers that we have, and to get good quality workers, you have to pay them. I mean, you can offer debt reduction, different things, but the best thing to offer somebody is a fair wage and a good salary. And I think you would find a fair amount of support for the idea if you came to us and said, we're just not paying enough, we're getting beat, and we had to try to find ways to raise pay for these workers. We want to do it. I mean, many of us are supporters of the Better Care, Better Jobs Act in the broader medical community of trying to raise nursing assistant and home healthcare aide wages through Medicare and Medicaid. I mean, I met a woman in Western Pennsylvania last week that is providing full-time living assistance to someone, getting her up in the morning, taking her to the bathroom, dressing her, feeding her for $8.25 an hour. I mean, that's what's happening for these hard jobs in a lot of our country where everyone knows we need these jobs done. We can't leave these people on their own. So I think if you folks at VA are able to come to us and show us, look, we need a competitive advantage here, we need to pay more, I think that's something we can really work on. So I would encourage you to put those facts and figures together and come back to us. Madam Chairwoman, I yield back.
Thank you.
Thank you, Mr. Lamb. And I just want to say I wholeheartedly agree with all of your comments and wanted the doctor to hear that. So I'm calling on the ranking member of the full committee, Mr. Bose, for 5 minutes of questions.
Thank you, Madam Chair. Doctor, while not directly related to today's hearing, the impact of the Delta variant on veterans is a top priority in all of our minds. Please, if you could provide an update on the VA's efforts to vaccinate veterans, particularly those who are elderly or high risk, but please also expand on what and if any additional restrictions VA nursing homes and or other high risk settings are putting in place to deal with the rising number of cases.
Yes, sir. I appreciate that. Yes, we're watching it very closely on the Delta variant and also looking for any clusters of breakthrough infections. Knock on wood, but we've had a very high rate of our vaccinations, especially in our elderly. We had a very strong push in the very beginning, especially those that were living in nursing home settings. I can get those statistics for you for the record, just so I don't misquote on accident. But yeah, we're very lucky on that. And both us and in our community living centers, we actually have a kind of a sliding scale based on some variables such as what is your community prevalence of infection, and if it's below or above 10%. Also are the rate of vaccination from the community living center residents, and also have there been any new infections in the last 14 days. And based on that, we up or decrease the levels of awareness, urgency, and limit potential limitation of visitation. So we really have that in place so that the local sites, based on those variables, can change, turn on a dime if they need to, based on their community. Because as you know, that from county to county, it can be very different. We're also been working closely with our state veterans homes to make sure that they are aware of this Delta variant, making sure, asking them more than they probably want to hear from us most of the time, about making sure that they have infection control practitioners in place, and then also making sure that the lines of communication are open. So we also are sharing that with with the states. So yes, we're very much watching this, and we'll just hope that we, and so far, again, things are, the vaccination rates are really helping us at this point.
My next question, because more veterans are choosing to age at home rather than in the nursing home or other institution settings. In light of that trend, how is the VA, and this is a big issue, because how are they planning to transition significant staff, infrastructure, budget allocations to institutional care towards a home, leave the institutional care and to go at home and community-based programs instead?
I think the first is us recognizing that that is an issue. Of course, many times the things in our budgeting system, if you make changes, and especially in our asset or allocation system, it may be a couple of years to really kind of balance out with if you've made a significant change for aging in place. So yes, sir, it definitely is a challenge. But at the same time, COVID in a way kind of helped us in the sense that we were already starting to try and not send veterans to facility care if we could, just for the fact of people were safer if they could to be at home. And we're also piloting things such as using predictive analytics. We have a pilot now to where we run every veteran in a region in 2 sites, and we find what's their risk of nursing home placement in the next year. And using those predictive analytics plus a care coordinator, they're proactively reaching out to veterans and working with their primary care team so that they can arrange for what home care services they need even prior to them coming into their provider with any concerns. So we're really looking at how can we step out and lean forward into this area to really help people even in a proactive manner.
Sure. And just a quick follow-up on that, how, if at all, does the AIR Act and the market assessment process that we're moving through right now account for an increase or demand with home care or community-based long-term, or does it have any effect?
At this point, even outside of any kind of market assessment, we're already leaning forward to see how we can expand home care, because once it's kind of the chicken or the egg kind of phenomenon. You've almost got to lead with one before you see potentially significant changes in the other. So we've learned a lot of things from the previous Medicaid pilots that's been done in many states, to where they've done things like money follows the person to help people already in nursing homes get back to home, and others. And there's really a lot of pilots that we're looking at doing to really see how we can adapt that to the VA and for veterans.
Wonderful. Well, thank you for being here today. And with that, Madam Chair, I yield back.
Chairwoman, you're muted.
I apologize, I'm muted. Congressman Mervan, you're recognized for 5 minutes.
Thank you, Chairwoman Brownlee. Dr. Hartrough, we know that older people, including veterans, are generally less likely than others to get appropriate assessments, referrals, and treatment for mental health issues like depression and anxiety. What is VA doing to ensure that all clinical staff caring for older veterans have the appropriate training and resources to ensure good mental health services are being offered in long-term care settings? And how does this translate for veterans cared for at home?
Yes, thank you, sir. Yes, we have been working very closely with mental health, especially with the Suicide Prevention Office and others, because we do recognize that. And to start off with our community living centers, we actually embed mental health providers, and we do everything from behavioral recovery outreach program to also train staff as how to really work with people and de-escalate and use non-medication related manners of how to help that. And also we have on staff in the interdisciplinary team, we have mental health professionals that can help with the care planning. When it comes to home care, especially like home-based primary care, which is provided by the VA itself, that includes mental health staff that's involved with the care whenever it's needed. We've also been doing many outreaches to include even hospice agencies through We Honor Vets and many other outreaches. So yes, sir, we're really trying to do our best to integrate and train folks that even whether we provide it directly or if we purchase it from them. So we're trying to find the care from others. We're really trying to make sure that we do incorporate that. And I've just been very thankful for the collaboration I have with the Office of Mental Health and other offices here within the VA.
And one of the reasons why I bring it up, statistically, we know that those numbers go up with isolation and with that home health care, making sure that we're taking care of our veterans and identifying and giving access to mental health via telemental health is extremely important, especially as you mentioned, your first answer was suicide prevention as a concern for all of us on this committee. My next question very quickly would be, as chairman of the subcommittee on technology modernization, I've been eager to learn how we can continue to improve the delivery of telehealth services for our veterans. Doctor, what are the current and potential applications of telehealth for home-based long-term care, both for patients and caregivers? Additionally, are there lessons learned from the COVID-19 pandemic in terms of providing such telehealth services?
Yes, sir. And just give you an example, in FY 2020, 54% of our video visits and asynchronous telehealth encounters were completed by veterans that were 60 years of age or older. So we have in COVID, one of the positives of from COVID was the fact that we had to adapt to using telehealth to reach veterans. So our number of actually increased to that was significant, even for home-based primary care and others. So what we're really doing is we're looking at everything from increasing our telehealth from our community living centers to our emergency departments. We're looking at telehealth to help our state veterans homes to get specialty care at the VA. So we're really looking at how can we keep the veteran where they're at, whether it be at home, whether it be in one of our facilities, so they don't have to transit between sites. And as you know, what we learned with COVID, so they don't become exposed by leaving where they live. So yes, sir, we're definitely looking at how we can integrate and even further our use of telehealth and other modalities.
And again, just bringing it home to localities within my district, one of the closer, larger institutions is Jesse Brown. So I'm from Northwest Indiana. And that could be with construction during the summertime, a 3 to 4 hour trip from 30 to 40 miles away. And as we talk about preventative measures, but also compliance, making sure that our veterans are compliant when it comes to their medication and their visits, telehealth opens the doors towards that. And so I want to advocate the importance of making sure that on the mental side and also on the preventative side, how important it is, and to continue down those paths. So I thank you very much, Dr. Hartrough.
Thank you, sir.
Thank you, Mr. Mervan. And we will now move to Dr. Murphy for 5 minutes of questions.
Thank you, Madam Chair. Just working the screen here. Thank you guys to the panelists who've come before us today. I'm very appreciative that you take the time for your testimony today on the important issue about aging in place. I'm very appreciative of the work that you guys are doing. I'm proud to represent approximately 89,000 veterans, which is the 6th largest congressional district for any veteran population in the country. About 32,000 of those individuals are 65 or older in my district. I'm a practicing physician, so it's very, very important to me that each individual veteran in my district has access to the treatments and support that they need whenever or wherever it is needed. While I recognize that some treatments can only be offered at highly specialized facilities, it's safe to say that an overwhelming majority of these treatments and appointments do not. Today I come to the hearing a little bit concerned about the veteran community-based care, ranging from a little bit from basic home care to still home care, is still not offered at a consistent level in my district. It's spotty at best, to be very honest with you. Listening to veterans' input is the most practical and effective way to determine where veteran health care can be improved. I've heard from constituents that the VA is now placing more emphasis on telehealth and remote care, even with complex issues. And so in June of 2020, supporting claims said the telehealth or the VA Video Connect increased 1,000% during the pandemic. Again, as a practicing physician, I understand the use of telehealth and remote care. In fact, I think it's actually one of the silver linings that occurred during the pandemic. I've been a big proponent of telehealth for many, many years, and it's been difficult to get insurance companies and even Medicare involved. And so it's really good to see that. I am concerned, however, though, sometimes we over rely on this and we become a little bit too complacent in that regard. And so I just know that telehealth, while it providing a definite advantage to our seniors, especially mobility-wise and getting out, there needs to be a few safeguards in that. So let me ask this one question as we get through. Given the advent of telehealth, can you walk us through the process of how you determine, when you determine or not to treat a veteran using telehealth? And actually to further that, well, actually, I'm just going to let you answer that question, then I'll follow up. Okay?
Yes, sir. I guess, as you said, COVID really had us pushing our what we had ever done in previous boundaries with telehealth, for lack of having any other modality of reaching the veteran, including veterans not wanting outside folks to even come in their home, much less going see folks. So I think we're at that point now. We got to come back and look at what is the right level for the right people, because it really, as you said, it is about the individual and how they best interact and what's the condition. So what we really do right now is we're coming back to face-to-face visits. I myself am a geriatrician, so I agree. There's a lot of stuff you can't do on telehealth. To me, it's all about the individual, and the only way to really work that is between the primary care provider and that person as to finding out what works best for them and how much of that. So it's hard to put a blanket statement, but to me, it's more of an individual based decision.
Sure. I'm a little bit worried, and let me just follow that back up, that some physicians or mid-level practitioners really don't have the experience, the clinical experience, and tend to treat things visually over the computer screen or whatever via telehealth. When you and I both know if someone has a wound, you can't really see it very, very well on a screen, and you can't really tell about what's going on. So if, and maybe you guys haven't done this yet, if someone is going to be prescribed to be treated telehealth, do you or should you at least entertain that there be some type of protocol where, regardless of their telehealth status, they are still seen in person, regardless of the convenience of it or not, that they are seen in person to just re-examine things and then go back into a telehealth kind of scenario?
Yes, sir. What I can do is bring back to you from the telehealth office, who really has the best protocols. I don't want to misinform anybody, but actually one of the things we're doing is working with a moving forward plan. And what we're doing is each specialty is setting their standards as to how do you swing the pendulum back and what can that be done for. So it really is looking at everything from privileges to clinical practice guidelines. But yeah, we're definitely, and I'll check with the Office of Telehealth to see if they have any more specific things that I can give to you. But it's really specialty dependent, because as you know, there's some specialties that just require the hands-on versus others that can, to a point, do more of the virtual.
Right. And I think just being aware of the great functionality of telehealth, but also the major downfalls. Thank you, Madam Chairman. I will yield back.
Thank you, Dr. Murphy, and I will now call on Congressman Sablon for 5 minutes of questions.
Yeah, thank you. Thank you, Madam Chair, and thank you for today's hearing. Thank you also to the witnesses for coming before us. I have a few questions, all hopefully addressed, could be by Dr. Hart. I'm gonna try this, Hartrough, or Dr. Kelso. Dr. Hartrough, how do I say your name, sir, please?
I can go by Scotty if that's easier.
Okay, thank you very much for that.
You're welcome.
I'm in Congress since 2009, and one of my long-standing goals, I don't know if we can get it done soon, but is to provide a community-based outpatient clinic in America, a CBOC. I believe that my district is the only state or territory that has no CBOC, and along without a CBOC, we don't have a vet center. We also do not have access to any of the home and community-based services that we're discussing at this hearing today. As I understand it, the president has proposed a 10% increase in your department's budget for fiscal year 2022. And throughout your testimony, you discussed the strides the VA has made to increase access to these services, yet the veterans in my district still don't have access. So when will the VA make the Marianas a priority for VHA services, such as the home and community-based care?
Yes, sir. As for the first part with the clinic, I can check with primary care and others and get back with you as to anything that they've got in the works. As for home and community-based services, I can reach out to VISN and check to see if they've already got plans to how home and community-based services within your specific area what are available and things like that. So I don't have that information right in front of me specific for your area, but I definitely can get back with you.
Okay, I can tell you that this community, community and home visits are not, home and community-based care is not available in my district. And the committee and many VSOs have indicated the importance for the VA to ensure that its long-term services and support can accommodate special populations of veterans, such as women, the LGBTQ community, Native American, the American Indians, and the Alaska and Native Alaskans, Pacific Islanders, and veterans who live in the U.S. territories and rural and remote areas. So, as a matter of fact, veterans residing in Asia have been reaching out to me through their VFW comrades to help them with issues from reimbursements to COVID-19 vaccines to other issues they have trouble navigating through the system. I'm barely afloat with the issues of my own veterans, so I cannot help others, but I just cannot ignore them as well. And there are no easy asks these days for veterans who reside in truly remote areas, but the asks are vital. The VA must ensure that all veterans have access to many of these life-saving services. So what, may I ask, is the VA currently doing, and what will the VA do in the future to ensure that services, the VA services, are not only available, but accessible for all of the special populations of veterans, including the veterans who reside in the Marianas?
Thank you, sir. I think part of that too is really for us understanding the differences and the needs for each of the subpopulations. We work closely with the Women's Health Group as well as the LGBTQ plus office and the Office of Equity, Healthcare Equity. So we definitely are looking in the area in which you know, in your district. It is tougher because, as you know, there's not many of those services even available in the community. But what we are really looking at is how can we provide equitable care. And then also there's also some special population liaisons at VISNs that are part of the transformation plan. So we really are looking at it. But the first thing is assessing, because some of those populations will have different needs as they age than we've been traditionally used to taking care of. So yes, I think we're going to be in a constant learning pattern, but also being aware and finding out what each of those populations where they're at need.
Yeah, Madam Chair, my time is up. I will submit some questions for the records. I want to thank Dr. Scotty for responding to my questions that I have asked on many other occasions we have. But thank you very much. Have a good morning.
Same to you, Mr. Sablan. I will now call on Congressman Roy for 5 minutes of questions.
Thank you, Chairwoman, very much. Appreciate it. And I've caught most of this. I haven't caught every question, so I hope I'm not duplicative in any way, shape, or form. But look, I just want to thank the witnesses. Thanks for your time. You know, a couple of weeks ago in San Antonio, you know, I represent Audie Murphy in San Antonio, and we had a great discussion down there with Mr. Sandals and the team down there. And I think this is really, obviously, really critically important conversation. One of the big focuses that I've had with my staff and with VA is looking at ways to give veterans more control over their healthcare, right? Obviously, that's something that's been significant here. I think for all of us, I think maybe particularly on the GOP side, but I think generally. And I think one of the things that that's interesting is the Veterans Directed Care Program, right, which provides veterans with a personal budget that the veterans or caregiver can use to meet their long-term care needs as they see it. And what sets that apart, makes it successful, is the freedom that it gives to veterans to choose the services and supports the needs that help them and help their individual needs. So I think my question is, one of the things that I think is important is, would it be worth considering how other VA programs could be adapted to take a similar approach? Are there other ways in which we could kind of go down that road?
Yes, sir. Yes, and we're looking at pilots as to looking out of our traditional ways we've been doing things, including pilots with both our Medicaid partners. We're also looking at how we can make this more of a person-centered level of care. As you said, how can we look at our current programs? So the short answer is yes, we are looking kind of out of our traditional box to see how we can make things more where they can make their own decisions, and then also working with our partners and other federal agencies so that we work together, both in CMS, HUD, and other departments. So yes, we're definitely looking to how things we can be done differently.
Thanks, Dr. Hartrough. I think one of the things that I'd like your all's input on, not necessarily in this 2-minute deal, we do these hearings, you can only have 2 minutes conversation, and that only gets you so much. But if we could have an extended conversation, I introduced a bill, HR 1520, the Veterans Access to Direct Primary Care Act, and it would create a pilot program through the Center for Innovation established by the Mission Act and allow veterans to access direct primary care arrangement with VA dollars. Now, I think direct primary care is something we need to be advancing and pushing more in the private sector and in the civilian world as well. And I'm working on efforts to do that. My friend Dan Crenshaw and I have been working on these ideas. But I think it's something that might be valuable or could be valuable in the VA community, right? And ensuring people can have access to go to a doctor of his or her choice in a direct primary care type arrangement, right? Where you're paying X a month and you're getting sort of the full service that provides, and try to kind of change that paradigm, give you more control and relationship, and have the cell phone of your doctor. It's the old black bag doctor that, comes to your house kind of concept that I think we're trying to expand in healthcare generally. And so if you agree, I'd love to have a conversation after this a little bit more about ways in which that might be possible, at least ways we could consider it.
Yes, sir. And also there's an Office of Primary Care that's outside of my program. So I don't want to speak on their behalf, of course. I don't want to do that. So, but yeah, definitely we can have further conversations or other like roundtables or anything that might be helpful. But if it's over primary care, I'd want to make sure we get the right folks for y'all to talk with.
Sure. And I think so. The reason I brought it up here, though, is in terms of the flexibility and the specifics of being able to give people that flexibility that a direct primary care model gives you, where you're having that type of option with physicians. Let me ask you one other thing. I got a minute left. There's been a couple questions related, pandemic related matters, but what I just wanted to ask you really quick, what are the current requirements for individuals to visit loved ones at VA community living centers? If that's already been covered, forgive me, but that has come up multiple times by constituents that I represent, and that you can visit your loved ones, but you have to go outside. There's certain social distancing things, and recognizing that we've got the Delta variant, some of these things that have popped up, we still want to be able to move forward and allow human beings to relate with fellow human beings. So I just want to know what the status of that is with the VA.
Yes,
Thank
sir. We actually, as mentioned before, we kind of have a sliding scale. So every site could be a little different based on their own unique characteristics of their county. So what we do is we look at 3 or 4 variables in the sense of if their county prevalence rate is above or below 10%, if the community living center residents are vaccinated, over 70% of them are not, and when was their last known case that was in that facility, whether it was 14 days or more. And then also what we do from that is it's based on whether, you can have visitors into the core of the facility. And what we're trying to do is whether we've allowed guidance for outdoor visits, for patios, balconies, because the part of it is protecting that very core where all of them live together from having folks coming in and out of that. So it does vary from site to site based on their unique characteristics of that county. And we ratchet it up based on that. But we also allow for compassionate care visits are allowed though, especially for those in hospice. So I hate to give you an answer, but it really depends on each county, but we do have it set for each folks to use based on what they have.
Well, Doctor, I'm out of time. Thank you for your answer. I would just encourage you, whatever we can do to allow for human-to-human interaction, it's a must. I mean, we've just got to. It's good for mental health and well-being. God bless. Take care.
Thank you, Congressman. I now recognize Congresswoman Underwood for 5 minutes.
Thank you, Madam Chair. I want to begin by thanking Chairwoman Brownlee for her steadfast leadership on this issue. You know, the Chairwoman has been dedicated to making sure that we pay attention and we prepare for the demographic trends in our veteran population and the ever-increasing need for long-term services and supports. The median age of veterans in the United States is 65 years old, and the healthcare needs of the veteran population is complex. According to a Government Accountability Office report published last year, the VA projects that the department expenditures on long-term care will double by 2037. The GAO report also found that a growing share of the VA's long-term care expenditures will go towards non-institutional programs as demand for home and community-based services increases relative to institutional settings like nursing homes. Veterans deserve access to care and services in their preferred setting, and we need to make sure that evidence-based interventions and investments are made to ensure that veterans have the option of receiving long-term services and supports in their homes or communities now and in the future. And one critical area of focus has to be on the workforce. In the 2020 GAO report on VA long-term care found that nationwide shortages of geriatricians and palliative care providers, which will affect VA's ability to provide long-term care services to veterans in the future. So to Dr. Hartrough, in that report, GAO noted that the VA's Geriatrics and Extended Care Office had not established measurable goals for its efforts to address workforce shortages, such as staffing targets to address the wait list for the home-based primary care program. In response to the report, the VA committed to setting measurable workforce expansion goals. Can you provide us with an update on the goals that the department has set and any initial progress towards completing those goals?
Yes, ma'am. Thank you for the question. The Geriatrics Extended Care has set a series of milestones to include goals specific to geriatrics and palliative care workforce shortages. Some of the milestones include identifying incentives and bonus program opportunities for geriatric workforce, prepare and also working with the VISN and other leaders to develop toolkits as to them as to how to both recruit, train, retain, and also develop the other pathways. We've also proposed a pay table increase or change for both geriatrics and palliative care physicians from their pay table 1 to pay table 2. The final results are still pending. We're also collaborating with both the Office of Nursing, which of course makes up most of the staff that provide care to geriatrics, especially direct patient care. But we're also working with the Office of Academic Affiliations to increase potential training for both nurse practitioners and physicians of both of those types. As you know, the VA has been a trainer of many of those specialists that end up going in geriatrics, including myself, that was trained in the VA when I was active duty military. What we also want to do is we've also started everything with educational debt reduction. We've also worked with nursing as to how we can find any other steps or incentives. But we've also started training. We've got a Geri Scholars program where we actually bring primary care and other specialists into a training site. We teach them about geriatric syndromes so that they can operate at the highest level of their competencies and yet expand, because there'll never be enough geriatricians per se to care for the population that we need. So it's kind of a multi-step process that we're looking at to address the workforce issue.
Thank you. I'd like to finish by turning to a different GAO report that was published in 2019, assessing improvements that would be needed in the VA's facility planning efforts to ensure that the department meets the evolving needs of our veteran population. One troubling finding from that report was that the VA was not systematically collecting data on whether demographic groups differ in their expectations for how they would receive care. Without demographically disaggregated data, the VA will not be able to allocate long-term care resources consistently with the preferences of all veterans. And so can you briefly describe in our last 30 seconds how the VA is tracking the long-term care needs and preferences of veterans broken down by demographic variables like gender, age, location, race, and ethnicity?
Yes, ma'am. There are many areas that we are looking at, including the demographics of rurality. We're looking at gender. Well, I think we still have a lot to learn as we do have the increases in some of the subpopulations, especially women veterans, and some of the unique challenges they have or differences they've had with our traditional male population. We also have been working with other offices, the Health Equity Office, and also we should be coming out with some studies to look at how we are doing with both equity among subpopulations. So that is an area that we are currently looking at under health equity and other measures to make sure we're not missing any of those aspects.
Great. Well, we look forward to hearing those updates. Madam Chair, I yield back.
Thank you, Congresswoman. I now recognize Congressman Rosendahl for 5 minutes of questions.
Thank you, Madam Chair. Appreciate you putting the hearing together. Mr. Hartrough, one thing that sets the Veterans Directed Care Program apart and makes it successful is the freedom it gives a veteran to choose the services and support that best meet their individual needs. Why don't we consider how other VA programs could be adapted to take a similar approach?
Yes, sir. I think at this point, we're looking at many different efforts of how we can look at out of our traditional box, which as mentioned earlier, that we're looking at everything from working with the states with managed care. We're looking at veteran directed care. We're looking at how we can even do predictive analytics to proactively reach out to veterans before. And so, yeah, we're really starting to look at differences as to how we can to make those changes to make things easier and improve our access.
So are there any specific programs or systems that you would recommend to use this new approach?
Well, at this point, it's still the veteran directed care program is still probably the best avenue to really look at how people can meet the needs and long-term service and supports because they have from ACL and others. But again, I think that we can take a broader look as we're looking at checking all of our programs as to what can we do different now in the future than what we've done in the past. So I think it is something we need to look at through a new lens for all our programs.
How does the budget that's provided to veterans in the Veteran Directed Care Program differ from the compensation benefits administered by the Veterans Benefit Administration?
Yeah, I don't want to misspeak on the veteran benefit side since that's not my background, but more the veteran benefit background from my understand is the more the funds are provided for them, rather with us and the veteran directed care, they actually get counseling as to someone that'll help them to find potential employees. They'll help them with any state laws of what it takes to essentially hire someone to make sure running afoul potentially of any of the state laws and taxes and other things like that. So some of the benefit of us working with the Administration of Community Living and our partners and the Administration for Aging is really that giving that person that, the background of basically a business of how to hire people rather than just be giving them money and then you have to kind of do it on your own.
Mm-hmm. So on the long-term care, that was trending towards more of a home-based care and away from institutional care before the pandemic. Did the pandemic and particularly the outbreaks in the nursing homes and state veterans homes accelerate that trend?
Yes, sir. We definitely knew one of the lessons learned is the need for expanding home and community-based services as well as telehealth and other modalities when we just can't get people into their homes, much less we don't want to potentially expose them to, infectious agents and outside. So yeah, we've really learned a lot from that. And both we're wanting to, work with both VA provided healthcare as well as some of those that are purchased through agencies. But yes, we've learned a lot through COVID.
And are you collecting enough data and have you had enough data collected to start measuring the difference in the outcomes of whether the institutional facility or being treated at home, if the outcomes, have we seen any differences in that yet?
I think we're still a little too early for being able to check to make sure that, how far we want it done. But also we've been working with the Office of Veteran Experience Office so that we do a veteran's journey through how they get into the system and the other. So we ask our questions of, instead of the traditional satisfaction questions, we're asking them more about so I think there's still yet a lot to learn before we can really draw that conclusion.
Okay. The VA's budget states that despite increased veteran demand and need for home-based primary care, growth in the availability of home-based primary care is slow because of the startup cost and the slow return on investment. When they make those statements, are they taking into consideration, and that's the point I was trying to get to previously, the outcomes? And if we have improved outcomes, then obviously on the back end, we're going to be having an incredible savings, not to mention the fact that we just have a healthier population. So when we look at those numbers, are they taking that into consideration?
I can't comment specifically on that quote or that source, but I can say that some of the VA provided home and community-based service, for example, we do have outcomes showing that it decreases hospitalization, their satisfaction is high. So in a way, it's kind of that traditional thing of that upfront investment, knowing that, as you said, it's longer term savings, and it may not be immediate, but it is more longer term.
Excellent. I see my time is up. I would yield back, Madam Chair, and I'm hoping that we can start gathering that data in the future so that we can have a good, accurate picture of what we're dealing with. Thank you.
I agree, Mr. Rosendale, and I think to follow up on one of his questions, I think one of the lessons learned during COVID is the need for home care to get as many people in home care as we possibly can. So. Thank you, Mr. Rosendale. And I now call on Congresswoman Frankel for 5 minutes of questions.
Thank you, Madam Chair, for your leadership. And thank you to our panelists today. I recently met at home with many health home care workers. And one of the things, obviously, we know how difficult the job is. It's very, very low pay, which needs to be changed, and which is, I think, one of the reasons we must make sure in our next human infrastructure package or job package, whatever we're going to call it, that there is substantial funding for home health care, because it appears that there's the shortage of home health care workers is in the hundreds of thousands and will be as people age. And so this is not just a veteran affairs problem, it's across the board. So, my question, sir, is, are you working across agencies in the administration to try to remedy this? And I would you agree that just that the low pay and the lack of supporting professionalism is a driving factor in the scarcity of the worker?
Yes, ma'am. Overall, it's a really tough job. I myself started off as an orderly many years ago, and taking care of family members when they've been ill. So yes, it is. I mean, it is really backbreaking work sometimes. So it is difficult. And then also, as you said, depending on where you live and locality and cost of living, it is a tough issue for many reasons. It's very difficult. And as you said, both in the VA and outside the VA, there's large turnover rates and other things that one has to work with.
How much does the VA pay the home health care worker?
Ma'am, I'll get back with you on that. I didn't have that prepared for me, but I will get back with you on the record.
Well, it seems to me that is the driving factor. And I've just, so that is very important information. Especially, it's necessary. I know for, in most instances, I don't know what the VA pay is, but in most instances, it's something like $10 an hour, which is very, very inadequate. And until we can get this pay bumped up to at least 15, and it's, which is not even, you think about it, a plumber gets more. Not that I don't have high regard for plumbers, but come on, we pay plumbers more money than we pay our people who are taking care of our disabled and our elderly. It's just, to me, it's disgraceful. So I would just urge the VA to take a look at how much you are paying your home health care workers. Start the trend, bump up the pay. I tell you that'll go a long way in solving the problem and trying to get more people into the profession. The other question I have, which is concerning the VA's program of comprehensive assistance for family caregivers, which is also another, to me, a wonderful program to support our veterans. My office has heard that there are tens of thousands of veterans whose applications who the program are pending. Could you, enlighten us on that?
Ma'am, that's not in my usual area, but I can get back with you on that with the program, the caregiver program office. My apologies.
Yeah, that's okay. I do think, Madam Chair, that is a program that could, especially given that there's a shortage of home health care workers, the family members being able to get support. This can include training, this includes funding, would be important in a way to sort of close the gap. And then, so let me ask another question, which I know goes to the, I'm running out of time. So I'm going to yield back, Madam Chair. I was going to ask a question on whether they were specifically looking at some issues in regards to women. I'm going to leave that to you. That is your, you've been a leader on that. I thank you again, and I yield back.
Thank you, Congresswoman. And, thank you for bringing up the, interagency possibilities as a remedy for some of these programs. And I think it's, fair to say that Medicaid and HHS is doing a better job of rebalancing within their program than we are doing in the VA. So I think they are lessons to be learned there as well. So I see Congresswoman Miller Meeks is here. I recognize you for 5 minutes of questions.
Thank you so much, Chairwoman Brownlee, Ranking Member, and all of our witnesses in this testimony today. It's interesting that not only am I a veteran, but I am a physician, but I was a nurse and married a nurse. And both of us in our younger lives, as we established our careers, actually did home care for veterans. So we've delivered home care, and especially my husband have worked in that area and with paralyzed veterans. So this is interesting testimony and information. And some of the questions I ask are more related, not just to VA home care, but to the entire aspect of how we care for our elderly. And as a state senator, I have this same question. So you listed for us the variety of different programs available to care for veterans and to care for veterans in their home. And I think all of us would certainly agree that aging in place, aging in our home is certainly preferable. Even in as a commissioner at our own Wapello County Veterans Commission, we have raised outside money in order to help veterans stay in their home by replacing their roofs, replacing their furnaces, helping with a vehicle for transportation. And so the cost of keeping people in their home is actually quite significant. And I'm going to ask you the same questions that I ask of our home care providers and industries in Iowa as a state senator. And that is, given all of the varieties of programs that are available to keep people in their homes and prevent them from going to a nursing home, we constantly hear the refrain that it's cheaper to keep people at home or less expensive. It's certainly the most desirable, no question about it. But cost-wise, it's less to keep people at home than it is in a nursing facility. And we know that individuals receive a variety of these services, not just one service. So the question I have is, have any of you looked at, given all of the variety of services that are available, what's the cost comparison? Is there that large of a cost differential? Not that cost is the only thing, that's not my point. I'm just saying, have we looked at things in their entirety rather than just individually what's available?
Yes, ma'am. I think, again, we've learned a lot from the Medicaid expansion pilots that, when the money follows the person demonstration that has helped a person go from a nursing home back to their home. And they have considerable data and publications showing that. I think most of those, once you bring them together, really show that it does take upfront investment in home care, but then it does have long-term cost savings. It's just that upfront that does take additional funding. So yes, I think we've gotten several of our publications in the VA, especially by program, like home-based primary care, for example, and which includes also medical foster homes. So yes, both we and Medicaid and other parties have really shown that there is a savings with that. Different based on the population, subpopulation, of course, that you're looking at.
And if we were to do as was suggested just with the past representative, if we were to raise salaries and increase compensation for home caregivers, have we modeled out what that cost would be to our programs? And I think that's the same thing would apply in nursing homes as well.
My apologies, ma'am. Yes, I think that's something we need to look at a little bit better as to what we're working with workforce management as to what would that, how much does that work? Because we haven't really modeled for the different levels of salary changes and things like that. We know with our current model, it does a cost savings, but that is we can improve on. Yes, ma'am.
Thank you. And also, do the trends that we see in long-term care in the VA match the trends in the private sector? We've certainly seen trends in the private sector towards more aging at home, aging in place, and especially given the pandemic, we've seen that trend, I think, accelerate. Do you see the same thing happening with the VA, and why or why not?
Well, I just give an example of some of our trends and in our non-institutional care programs. Our homemaker home health aid between FY18 and FY20 increased by over 10%. Veteran-directed care increased by 41%. Home respite increased by almost 7%. So we are showing gains, but I think there is yet improvement that we can be made significantly if we really want to make that availability for complete aid in place. That is really our focus now. So we really do. That's why our strategic plan, the first pillar in our strategic plan, is finding ways to expand home and community-based services for aging in place.
Thank you so much. Thank you, Chairwoman Brownlee. I yield back my time.
Thank you, Congresswoman. And before we conclude this panel, I have a few more questions. And if any other members have additional questions, I will call upon you. Dr. Hartrough, I wanted to ask you, there's been a lot of conversation in this back and forth about plans and timetables and so forth. And so I know in your written testimony, you talked about there were seven areas that you point out were highlighted in the written testimony. In your testimony today, it seemed as though they were a little bit different. If I heard it correctly, it seemed to be consistent with the GEC transformation plan that has been put out. This plan, it was back in 2017, I think, where there was a commitment to create and move forward with a transformational plan in this area. And right now it's only a two-page document. So I always feel like a plan without a plan is a plan to fail, that we need, we need more detail here, and certainly our ability from the committee's perspective to be able to oversee that and make sure that we're meeting the timetables and dates of what we're trying to accomplish. And it also seems to me like we should have, rather than just saying we've got to improve all of these programs and we want to do more pilot programs and we want evidence-based and we want all of those things, I think generally we should be looking at, we want to rebalance and we want to get to a different ratio than we are currently. And so I just think that we need, a more detailed plan, which I would really, really like to see. This is really important to me. It's, since I've been on the committee, reforming sort of this long-term care for this bubble that is going to move through the VA is extremely important to me. So I'm going to stay focused on this, and I'm not going to let anybody off the hook. So I'm just giving you a heads up on that. The other issue I think that's important, in terms of what might be a barrier in terms of this whole rebalancing effort is it seems as though the institutional care dollars are really coming out of dedicated accounts that are controlled by VA Central. And the non-institutional programs are being funded more through the VA medical centers and the like, having, those centers having more flexibility around those non-institutional programs. So my point is if the VA medical centers don't have any skin in the game, the institutional care is sort of there, the system's created, people are just going to keep going back to the institutional care because, they don't really have any skin in the game and there is no accountability for them to be moving towards these programs that we know are more effective and more preferred by the veteran. So I just wanted to make that point. And the last point that I wanted to make was the Wounded Warriors had written testimony, and they're really focused on veterans who served on or after 9/11 and their need for home-based care. And so I just, I really wanted to point that out. And some of the barriers that they talked about are just knowledge of the programs and access to the programs, even going as far to say, if there's a geriatric program, they would immediately assume, well, that's not for me. I'm a younger veteran. I'm not an older veteran. Geriatrics is for older folk. And so I just, I wanted to highlight that because I think it's really important that we say, razor focused on that population as well, who needs this, and I think will benefit from it. And I think a lot of these home-based programs, I think generally can be somewhat realigned into almost, sort of like one non-institutional care program, more or less. I mean, even the respite program, for example, like, okay, so I'm in the veteran-directed program. I don't know that I can apply to the respite program and relieve some of my workers that are coming to my home and are exhausted and need to be refreshed a little bit, for the quality of my care. So, the respite program to me should be an adjunct to every single one of the home-based programs and not sort of its separate program. So those are the sort of the things, that I just wanted to add to the conversation, and I appreciate your attention to them. And if any other members have any other questions before we move to the next panel, just, let me know and I will call on you. And I don't see any hands raised. So with that, there's no further questions for the VA. I know I've asked my staff if we could have another meeting in my office so that we can drill down on this more. And I really want to follow up on that and have it sooner versus later. So I thank you, Dr. Hartrough and Dr. Kelso, for both being here. I know that you had to kind of fill in for someone else who was unable to attend. So we appreciate it. And you are excused, but I hope you'll listen to the next panel. So our next panel, we welcome you, and I assume I see Mr. Butler. Oh, I see both of our panelists. So welcome to both of you. We're pleased to have representatives from your organizations. And first, I would like to welcome Ms. Rashi Romanoff, Vice President for Program and Partnerships at the Elizabeth Dole Foundation. And also joining us today is Mr. Roscoe Butler, Associate Legislative Director at Paralyzed Veterans of America. We'll begin with Ms. Romanoff. You are recognized for 5 minutes. And just pause a little bit before you begin to speak so we can hear your full testimony. With that, you're recognized.
Chairwoman Brownlee, Acting Ranking Member Radewagen, and members of the subcommittee. I am pleased to testify today on behalf of the Elizabeth Dole Foundation about the future of home and community-based services. Founded by Senator Elizabeth Dole in 2012, the Elizabeth Dole Foundation is dedicated to empowering and supporting our nation's 5.5 million military and veteran caregivers. These are the spouses, parents, family members, and loved ones who care for our wounded and injured veterans. I am honored to be here today to represent their voices. Today's hearing couldn't come at a more important time. According to a 2020 GAO report, the number of veterans aged 85 and older is expected to grow to more than 5 times over the next 20 years. There are several critical challenges facing the VA as it approaches its long-term care strategy, including workforce shortages, geographic misalignments of care, and meeting the specialty care needs of our veterans. Given these significant hurdles, we believe that support for veteran caregivers should be an integral component of VA's long-term care strategy. Already each year, our veteran family caregivers are providing more than $14 billion in uncompensated care to our veterans. $14 billion. This service is often provided behind closed doors, in the shadows, and without fanfare. But however hidden, this care and public service is critical. If not for the dedication and sacrifice of these family members, publicly funded systems like the VA, Medicare, and Medicaid would be simply overwhelmed with requests from aging veterans. So I want to thank you very much for including the perspectives of caregivers in this hearing today. While there are many lessons learned from the COVID-19 crisis, I want to just highlight 2 areas that have direct implications on long-term care. First is the increasing issue of burnout among caregivers. With COVID-19 came a reduced availability of home-based support, job loss, and the newly added stress of virtual schooling for children. As a result, caregivers were physically, mentally, emotionally, and financially strained. To address this need, the Elizabeth Dole Foundation partnered up with the VA, Wounded Warrior Project, USAA, and CareLinks to launch our Respite Relief Program last August. This program provides military caregivers nationwide with 35 hours of free professional home-based assistance. This can include everything from bathing and grooming to meal prep and even house cleaning. And to reiterate, it's completely free of cost to veteran families who have served either pre-9/11 or post-9/11. And the outcomes have really spoken for themselves. After receiving support through our respite program, the number of caregivers who rated their overall health as positive jumped from 44% before receiving respite to more than 90% after receiving their first visit from a respite care provider. We're talking about a 50% improvement in caregiver health after just a few hours of free respite services. We would like to ask this committee and our VA partners to promote the respite care program to veteran families in need. For example, given the recent influx in applications to the Program for Comprehensive Assistance for Family Caregivers, or PCAFC, and the large rate of accompanying denials, we believe that this could be a critical moment to promote the respite relief program to those veteran families who are reaching out in need of immediate support. The second lesson we learned is that the delivery of healthcare services in the home works. Home-based care, whether it's the provision of respite care or connecting with your care team via telehealth, in many ways eases the care coordination that oftentimes consumes caregivers behind the scenes. One promising program that we've talked a lot about today already is VA's Veteran-Directed Care Program. This provides veterans' families with in a way that puts their needs first. Rather than asking families to navigate different benefits, different application portals, veterans and families in this program are given a flexible budget to manage themselves. What sets us apart from other programs is that veteran families are in control. Veterans and caregivers together decide what mix of services best meet their needs, and they can work to either hire home-based support or purchase items and services that allow them to live independently. This is what a future care at home model looks like. Programs and benefits that have the flexibility to meet families where they are and give them control to direct their care. Currently, the VA and its Veteran-Directed Care Program is undergoing rollout, and we strongly endorse a faster rollout of this program. I want to thank you again for the opportunity to provide testimony on behalf of our nation's military and veteran caregivers. While all Americans will at some point encounter their own unique long-term challenges, the families of those that have served face mounting difficulties, and we owe them our support. Thanks again for your time and for hosting this important hearing.
Thank you, Ms. Romanoff. And I now recognize Mr. Butler for 5 minutes.
Chairwoman Brownlee, Ranking Member Radaragan, and members of the subcommittee. Paralyzed Veterans of America would like to thank you for this opportunity to provide input on the Department of Veterans Affairs, home and community-based services. The demand for long-term care for veterans with a spinal cord injury or disorder is growing. While the life expectancy for SCID veterans has increased significantly over the years, so too have the secondary illnesses and complications associated with both aging and SCID. As a result, most of the members rely on the support of caregivers and home care workers to assist them in meeting their daily needs. PVA believes that VA and Congress must make HCBS more accessible to veterans. One of the programs that should be expanded to all VA medical centers is the Veterans Directed Care Program. The VDC program allows veterans to receive HCBS in a consumer-directed way and is designed for veterans who need personal care services and help with their activities of daily living. Examples of the type of assistance they can receive includes helping with bathing, dressing, or fixing meals. It is also for veterans who are isolated or whose caregiver is experiencing burden. Veterans are given a budget for services that is managed by the veteran or the veteran's representative. Even with veterans have access to HCBS, it can be challenging to find home care workers. PVA member Stanley Brown, who became a quadriplegic following a service-connected injury in 1996, is completely dependent on caregivers to get him in and out of bed, dress him, feed him, provide his daily bowel and bladder care, and give him his medications. He is enrolled in the VDC program, but finds securing and managing caregivers is almost a full-time job. Like many veterans in his position, caregivers come and go regularly because the amount he can pay is so low, and numerous agencies or people are looking for the same workers for hospitals, nursing homes, and private homes. Over the last 10 years, he has had to interview more than 400 potential caregivers. The challenge of finding suitable caregivers is not unique to VA. Acute shortages of home health aides and nursing assistants are cropping up across the country, threatening care for older Americans and those with serious disabilities. A vigorous national effort is needed now to help curb the effects of these shortages and bolster the direct care workforce. As noted in our written testimony, the President's American Job Plan and legislation like HR 2999, the Direct Care Opportunity Act, or S2344, the Supporting Our Direct Care Workforce and Family Caregivers Act, seek to strengthen the direct care workforce through higher wages, better benefits, and sector-based job training and support. Another concern our members have voiced is the number of hours VA has been authorizing for their home care needs. Title 38 caps payment at 65% of the amount it would cost if the veteran was placed in a nursing home. This could result in upwards of 50 VA home care hours, but the amount being approved is far less. For 3 years, VA has been using a methodology that results in veterans receiving less hours than they need. While we recognize VA's challenge with limited resources, is it reasonable for VA to authorize 14 hours when a doctor who knows their patient best requests 28 hours? We believe that such little home care for catastrophically disabled veterans is in fact not reasonable. Finally, it is important that I talk about the need for veterans to retain paid caregivers assistance when they are hospitalized. For veterans with catastrophic disabilities, the need for a caregiver does not go away when a veteran is hospitalized. Neither community hospital nor VA medical centers are adequately staffed or trained to perform the task, and SCID veteran needs. Otherwise, the staff are not adequately trained in bowel and bladder care, proper transfer techniques, skin assessment, or other critical needs. In some cases, it simply lacks the available time to properly treat the veteran. My written statement also talks about PVA member Ann Robinson and Steve Kirk, who are high-level quadriplegics, which means they have no little or use of their hands. In closing, VA needs to rebalance its existing programs to ensure greater number of veterans can receive long-term care services in their home. In doing so, VA can prevent or delay placement of veterans in nursing homes and reduce costs. More importantly, it will keep veterans in their familiar settings of their homes, surrounded by their loved ones. PVA appreciates this opportunity to comment on some of the HCBS programs VA provides, and I'll be happy to answer any questions you may have.
Thank you, Mr. Butler. Appreciate you being here and your testimony. And I will now recognize myself for 5 minutes of questions. The first question that I had for both of you is just wondering, did the VA consult either of you or your organizations in developing this elder care strategic plan last year? And just yes or no, were you consulted at all?
PVA was not consulted.
And Ms. Romanoff?
Elizabeth Dole Foundation was not consulted.
Okay, and have you been briefed since the plan sort of been developed?
We have not, that I'm aware of.
Okay, very good. So, Ms. Romanoff, you in your testimony, you talked about the respite services that your Elizabeth Dole Foundation is providing. And, I'm just curious to know if there is, any coordination with the respite program that the VA offers and, how that works. It seems to me that the respite program within the VA is not that well known. Probably the respite care in the Elizabeth Dole Foundation is probably much more well known. And the statistics that you gave in terms of, the increase in quality of care is really astronomical. So if you could just comment a little bit about that, I'd appreciate it.
Absolutely. Thank you so much for the question. Yes, the VA is one of our founding partners in the respite relief program. We want to make sure anytime we design something that it's done hand in hand, it's not duplicative, it's not redundant, and it really complements their services. The way that we set this up is very intentional. This is not the long-term benefit. It's not something that people can use for 6 months or a year. This is meant to be sort of an introduction. So it's 35 hours. It gives you a sense of what respite care is. And the hope is that this could then become an entry point to educate people about respite care so that they can then go seek out the long-term benefits available at the VA. And I think, what we found is that, out of all the folks that we've awarded hours to so far, which is over 1,000 families, we've seen about more than 70% have never used respite care before. So what's great is that it is serving as that introduction. We're really excited about it. I think what's difficult is that once folks sort of use up that 35 hours and they start asking us, can we get more hours? And we point them towards the VA. As you mentioned at the beginning, they're just faced with a fragmented system where certain VAs have different processes, have different availability of providers. It's a much more disjointed process. And so while some people are able to connect and it's great, I know within the PCAFC program, you have access to respite care and some people connect and have a great experience. I think at other facilities, it's harder to connect. And so that's something that we're really looking forward to continuing to work with our geriatrics and extended care colleagues on, really making sure this is a seamless transition.
I thank you for that. And that's one question that I wanted to ask the VA and didn't ask the VA is that do they have a list of all of the programs at all of the facilities and what facilities are offering what, just that initial database to kind of get a snapshot of kind of where we are with some of these programs. So I appreciate that, Ms. Romanoff. So Mr. Butler, you your testimony, I think it was also quite compelling, and particularly when you described the waiting periods that your members, are experiencing. And can you just talk a little bit more about what your understanding is of why this is taking so long and what the VA should be doing differently? Is it just the fact that there's not a program where your particular veteran is to access, or is it something else?
Thank you, Chairwoman Brownlee, for that question. Our understanding, VA said that there were, with regard to the VDCs, there were 68. We were told that there were 69 VDC centers. So when you look at the total number of VA medical centers, 150 to 70 plus medical centers, that means that there are a large number of medical centers that does not have a veteran-directed care program. When we ask VA, why is that? Because it could result in significant savings. As you heard, VA has to pay cannot pay more than 65% of the cost of nursing home care. So it could result in a significant savings. And what we were told is that all it takes is a master social worker to manage the program. And so we're baffled why facilities don't see the advantage of implementing the program nationwide and not absorbing those cost savings.
Yeah, I completely agree with you. And I think this veteran-directed program is a program that, doesn't, like I said in my opening comments, there's not anything to sort of stand up. It's just a matter of a facilitator. And obviously a veteran might have to visit their physician to determine what their needs are and so forth. But it is just a matter of cutting a check, providing the service and an oversight to making sure that, veterans are getting what they need. And obviously the program has, sort of great satisfaction. So it's, I don't understand why the program is not, it's a very popular program, and a popular program means that more people are accessing it, and why we're putting up barriers to access, I'm not sure, but I'd like to obviously get the answers to that and see what we can do. So I'm over my time limit, and so I will now recognize Acting Ranking Member Hartrough for 5 minutes of questions.
Thank you, Chairwoman Brownlee. Ms. Romanoff, one thing that sets the Veteran-Directed Care program apart and makes it so successful is the freedom it gives a veteran to choose the services and supports that best meet their individual needs. Your testimony calls that model the future, because it provides, quote, programs and benefits that have flexibility to meet families where they are and give them control to direct their care, end quote. Why do you think the ability to self-direct is so important and necessary? And do you have any ideas as to how other VA programs could be adapted to take a similar approach?
Yeah, absolutely. Thank you for the question. So I think flexibility in being able to direct service based on your individual family's need is really paramount. And that's why veteran-directed care has been designed, I think, in a really thoughtful and meaningful way. As we've known, I think in recent years, even research around the social determinants of health have really showed that in each area of the country, veterans are facing a different set of circumstances. Potentially, maybe it's housing costs that are really difficult. Maybe it's finding adaptive housing that's a challenge. Maybe it's this in-home support. Maybe it's access to food. There's really a wide variety of different needs that different families have. And I think the sort of geographic variability of that really, exacerbates some of these problems, to say nothing of what the clinical condition looks like. I think Roscoe did a great job of talking about some of the families, but if we were to take any one of these veteran families needing support, the kind of care that one veteran needs versus another veteran is completely different. And so I think what's great about the flexibility of veteran-directed care is that it really allows you to say, as a family, what is it that we really need help with? And let's invest those resources, and I'll emphasize, and really spend those resources most effectively because they're in control. So they're not forced to use a transportation subsidy that they might not need, or a housing voucher that they might not need, but instead they're really consciously being able to say, well, these are what our needs are, and this is how I want to invest my dollars to be able to support those needs. I think whenever we think about, it is a future model. I think the more that we can put veterans and their families at the center of these processes, the better. I think Chairwoman Brownlee mentioned this really well in the beginning. Right now, all of the VA systems sort of exist, and families and veterans interact with home health aid and attendants, interact with PCAFC, interact with Respite Care. It's a caregiver having to go to all these different places rather than the system being designed around what are all of their needs. And so I think rather than, trying to ask people to go towards all these different applications and websites and apply, making it a more centralized, putting the caregiver and that family at the center of it, and then outreaching to them about their needs is really important. So I think the more that can happen, and I will say, if I was the VA, I would be outreaching on this respite relief program every single day. It's free. It's being offered to you. It's 35 hours. You can give every single veteran family, regardless of era of service. You could do that tomorrow. So the more that we can get them to sort of really engage in prioritizing this as outreach, the better.
I'm running really short on time, but Ms. Romanoff and Mr. Butler, as more veterans choose to age in place and delay or avoid long-term institutional care, how should VA right-size the significant staff, infrastructure, and budget allocated toward institutional care to ensure the appropriate emphasis on home and community-based care?
I think rebalancing requires proper planning, and VA needs to ensure that they're putting the right processes and procedures in place to plan ahead for the future needs of veterans' home care services. It's not, one fits it all, one shoe fits it all. So they need to make sure that the planning processes are inclusive of all the things needed to address home-based community care services. And as Chairwoman Brownlee and Rashi said, it's building it around the veteran and making sure that it's all inclusive.
Well, let's see. We're really so out of time. Chairwoman Brownlee, thank you. I yield back the balance of my time. All 8 seconds.
Thank you, Mrs. Radewagen. I now recognize Congressman Mervan for 5 minutes.
Thank you, Chairwoman Brownlee. Again, as chairman of the subcommittee on technology modernization, I have been eager to learn how we can continue to improve the delivery of telehealth services for our veterans. Both witnesses, what are your current and potential applications of telehealth for home-based long-term care, both for patients and caregivers? Additionally, are there lessons learned from COVID-19 and the pandemic in terms of providing such telehealth services?
I think telehealth was something needed during the pandemic, but I caution that telehealth does not replace the personal care services and the interaction, because veterans benefit emotionally, physically, and mentally when they're encountering other veterans, when they're encountering their care provider on a face-to-face basis. So while telehealth is critical and important, particularly in a time like the pandemic, it should not replace the face-to-face interaction that a veteran can share with his healthcare provider or a home health homemaker provider.
Yeah, and I guess I'll just say, I think what's exciting about, I guess, the last 12 months, if there's anything that we can say in that category, is really how many veterans and their families for the first time really might have interacted with telehealth services. So I think it does represent a new opportunity for VA to now engage with families and engage with veterans. I think investments in things like remote monitoring devices really allow you to get a sense of the veterans' health, maybe if you're not seeing them once every 4 to 6 weeks. I think there's new ways of using the technology that can be really helpful. I think it can reduce for a lot of people long drives to their local VA or having to coordinate a lot of different appointment schedules. So I think there's a lot of benefits. I know one thing that we're excited about is, are there potentials now to increase things like mental health counseling, telemental health counseling, family counseling? We now have an entry point into people's homes, and what are the other things that we might be able to tackle and really be able to serve these veteran families with? So I think it's a huge opportunity. I agree with Roscoe. I think, it's not meant to, I don't think anyone's trying to replace the in-person visit. That's always going to be necessary for folks with these kinds of complex conditions, but it is a real opportunity to think about how can we more innovatively and effectively deliver care.
Thank you. With that, I yield back my time.
Thank you, Congressman Mervan. And I don't think there are any other members with us for additional questions. So I think I want to make some closing remarks, but before I do that, I wanted to ask Congresswoman Hartrough if she had any closing comments.
I just want to thank the chairwoman again and all my colleagues for their work on behalf of veterans. Our veterans deserve to live out their later years in dignity and comfort, and I look forward to continuing our work on this issue. Thank you again to the panelists, and thank you to all our veterans for your service. God bless you. God bless America. Soy full.
Thank you. Thank you very, very much for that. And so I really thank both of you for being here, and, really want to stay in close contact with you, because my desire is to really, reform these services and put them into a package that makes sense. And Ms. Romanoff, you made the point, it's let's put the caregiver and the veteran at the center of all of this. I mean, I even think that the caregiver program that we've had lots of hearings on and so forth, and all of the home-based programs here, all can be kind of wrapped up into one, with a respite program to support all of those programs. And we can do all of that and improve the quality of care and save some resources that we can reinvest back into improving that care. So it just all makes sense to me. It's just, and it's a lot of just realignment. And it's also then about making sure that veterans have, one-stop shopping, that they can go and look for these programs and understand. When I told the story at the very beginning about a staffer on the VA committee trying to help her grandfather and the difficulty she's having, she's a staffer on the committee and, is having trouble figuring out this particular service and program to have her grandfather yield the benefits of. So, that's a problem. And that's all really got to get fixed. And I think, the VA is not turning their back on people who need help. They're just getting referred to institutional care and put in a nursing home in their communities. And that's, and 9 times out of 10, that's not what the veteran wants. And one thing I forgot to mention, Mr. Butler, you raised this in your testimony, is about the pay of these people who help and support these veterans. I know that most of those people who are coming into the home, not all, but a greater preponderance of those people are women. And women have children, they have childcare needs, they might also have an elder within their family that they need to take care of. So, we need to help to support them and Biden has this, families infrastructure plan moving forward. I think, all of that will help to support women, will strengthen our economy to get women back in the workforce working, but we need to pay people a quality living to be able to do this. This is hard work. And it's hard work. You're lifting people, you're moving people around, and it's the patient, not everybody can do it. The patients, around, dealing with older people who might have dementia problems and other kinds of things, it's just hard. And so, we need to pay them and pay them comparably to what, to kind of what they are doing. And the last point that I think Mr. Moran raised and others is sort of the mental health and where telehealth can really be helpful. It reminded me of, this was a couple of years ago, but there was a World War II veteran that came to my office who had actually written a book and told me about his story, about his discovery, that the fact that he had post-traumatic stress. And he, lived his entire life after serving our country in World War II, not understanding why he was doing some of the things that he was doing, and not having the outrage in his family. And finally coming to understand that he just hadn't lost his mind, that there was a real issue there, and what comfort actually that brought him. And he had tears in his eyes in my office, this, World War II veteran that was just, so relieved. And I think, as this older bubble comes through the system, I think there's still a lot of, particularly Vietnam veterans out there that are still not kind of facing up to some of their demons. And, and I think that, having concurrent mental health services that we can easily provide through telehealth to this care, it's not just physical care, it's the mental health care too that is going to give our veterans the very best care that they need, and certainly the care with the dignity I think that they deserve. So again, I'll just close by saying this is really important to me. I think I see great opportunities for making these kinds of programs better and really doing the rebalancing that I think is needed, but it's going to take all of us. And it's going to take PVA and the Elizabeth Dole Foundation and everybody involved to help us make a quality program. But I don't think it's going to be lifting mountains to be able to do it. I think we've got a lot of the foundation there. It's just a matter of, sort of organizing and being focused on where we want to go with all of this. So I thank you all very, very much. And until the next time when we're talking about this topic. So thanks again to all of you. And with that, I will conclude the meeting, but I know there's something I'm supposed to say at the end that I always forget. I say this without objection, that concludes today's hearing. All members will have 5 legislative days to revise and extend their remarks and include extraneous material. And with that, this hearing is now adjourned. Thank you.